Thank you, ma'am. And it's always a pleasure to come to Baroda. It's my hometown and the place where I did my MBBS and MD. And also be among friends, a lot of them known. And also a pleasure that my teacher, Dr. N.C. Mehta, is on the stage today, and Tyron, my good friend also. So a task given to me by Akash was to talk about something in hypertension and something to do with CKD. So I thought, since most of you are quite much better experts in hypertension management than what I am, but I'll try to see what different things we can do in CKD and what may be the future drugs which are likely to come. And that may be giving you some new idea as to what's in the pipeline also. So I'll just briefly talk about the epidemiology of hypertension, the current guidelines and treatment strategies, and what's in the pipeline, aldosterone synthase inhibitors, something about non-steroidal mineralocorticoid inhibitors, and angiotensin antagonists. So as you all know, the global prevalence of hypertension, I did not remind you that we are also having a large burden of hypertension and continue to have so, and maybe we'll surpass many others in the sub-Saharan African countries which have the largest burden. Again, hypertension is important cofactor, or rather at times by itself an important determinant of death. And as you can see here, the blood pressure is just above 110, a large burden of them with ischemic heart disease, strokes, vascular disease, and chronic kidney disease. And if it is more than 140, obviously that burden increases much more of the death. What about hypertension and CKD? I think this is the most important of all the slides that I'm going to show you, because if you see here that the blood pressure control is the only therapy, I would rather say, or one of the most important therapy to retard the rate of progression of chronic kidney disease. Many chronic kidney disease, because the etiology is not reversible, they will progress. And if you control the blood pressure, the rate of progression can really go down. As you can see here, if the blood pressure is uncontrolled to 170, the rate of progression is 10 ml of loss of GFR per year. And if we control the blood pressure nearly 130 or so, the rate of progression can come down to as much as 2 to 3 ml per year. Generally, we lose about 1 ml of a GFR per year after the age of 40, which is the normal loss that will happen because of aging. But with good blood pressure control, and this happens all across all the categories of patients, diabetic, proteinuric, non-diabetic, proteinuric, or non-proteinuric. So all category of patients, if you control the blood pressure, the rate of progression will certainly come down. So all patients with CKD require aggressive control of blood pressure. So what about the management of hypertension in these? So we all know that there is going to be a full session of the secondary hypertension. I'm not going to touch about it. But the most important thing is to take a low sodium diet. And there are a number of studies, both epidemiological evidence in the animal studies and everything, to show that the salt is a big culprit. So if you lower the salt, the blood pressure is likely to get controlled better. Of course, there are other things like good uninterrupted sleep, dietary pattern, especially with increase, especially in the early part of the CKD, one can use generous use of fruits and vegetables so that you get enough load of potassium. And potassium has a salutary or beneficial effect in management of hypertension. Weight loss, of course, is very important in the current era. Every kg of weight loss, 1 millimeter loss of blood pressure can happen. And exercise, especially aerobic exercises, are important. Having said that, coming to the pharmacotherapy, we all know that the 3 cardinal drugs that are used for pharmacotherapy of hypertension are ACE inhibitors or ARBs, calcium channel blockers, and a diuretic. But in the recent European Society of Hypertension, they have increased the beta blocker have been elevated, in the sense that earlier the beta blocker had been relegated quite low in the list of drugs which were there for managing hypertension initially. But now beta blockers have been put a pedestal higher so that you can use the beta blocker at any stage of hypertension if you think that there are other reasons to use them, congestive heart failure, or they have ischemic heart disease, or they have increased sympathetic activity. Moreover, it has also been suggested that you try to use a single pill or a combination of pills, so that the most important thing is that patients should take the medication, and we must do everything so the patients can take the medicine. You give it in the morning, because most people after the breakfast, if they take the medication, they don't forget it, and don't try to give it at any other times of the day. And there is no difference in giving the antihypertensive in the morning or evening. Earlier it was thought that evening medication or the bedtime medications are better, but now it is no longer so. And there are other drugs, of course, we'll go through them, a few of them in the session that follows. So again, re-emphasizing the point, the step 1 is ACE or ARB, was calcium channel blocker and a diuretic if they're not well controlled. And beta blocker can be put in at any time. If despite using ACE inhibitors, calcium channel blockers, and a diuretic, and blood pressure is still not controlled, which should happen only in 10% of the cases, if you aggressively use these drugs, then most of them will get controlled. And it is also desirable that you use a dual combination in step 1 itself, rather than using single therapy. And the most popular and easy to use an ARB and a calcium channel blocker. And then maybe add a diuretic or use diuretic earlier. But that is a triple combination. But after all this, there will be a small percent of the patient who will not be controlled, and that is where we need to do the additional therapy. In patients with CKD, the same things apply. That if the patient has CKD that is stage 1 to 3, use the same combinations, ACE, ARB plus CCB and diuretic. And then if they are not controlled very well, and if they are stage 1 to 3, one could add spironolactone. Spironolactone is an excellent anti-hypertensive therapy, 25 milligram once a day, especially if there is no problem with the hyperkalemia, which in the early stage of CKD may not be so, and then I'll show you some data to it also. In patients who are stage 4 and 5, you use the same things, and you probably may need to add a loop diuretic. But now there is increasing evidence that you use ACE or ARB plus calcium channel blocker and a loop diuretic in stage 4 and 5. But if they're still not controlled, then you can add a thiazide diuretic. Earlier it was thought that thiazides can only be used in very early stage of CKD because thiazides act on a distal tubule and they may not be so effective. But there is a very good data now to show that if you add thiazide on the baseline therapy, they are going to do wonders to the control of blood pressure. Of course, there are other therapies which can be added depending upon the indication, like SGLT2 inhibitors. If none of these therapies work, then one therapy which really works is a combination of minoxidil, beta blocker and diuretic, which I call as a bomb therapy. If everything else fails, usually this does not really fail. It is a vasodilator and therefore you get tachycardia, so you need to use a beta blocker, and it causes fluid retention, so you need to use a diuretic. So in the most difficult control to control blood pressure, I try to, at the end, when you're tired of everything else, then probably minoxidil plus beta blocker and a diuretic. There's going to be a talk about the RDN, and we shall see what data is there after all this pharmacotherapy is there. So what about the role of chlorthalidone? So this study, which showed that patients were already on ACE or ARB and were on diuretic, that is the furosemide, they were patients who were on, and they were also on calcium channel blockers. And when chlorthalidone was added to them, it showed a blood pressure decline of almost 10 millimeters of drop in the blood pressure. And when it was stopped later on, it again came back. So this shows that the chlorthalidone added to the basal therapy in stage 4 and 5 really shows the beneficial effect, and therefore it has been upgraded to also use this therapy in stage 4 and 5. Again, if you see here, because we are nephrologists, we are interested to see if there is a decrease in the proteinuria. Yes, there's some decrease in the proteinuria. Some reduction in the GFR because it is a diuretic. So you do get some reduction in the GFR, but if you stop there, it comes back. Tells you there is a hemodynamic effect and not really a permanent effect in the reduction in the GFR. So in patients who are difficult to control, stage 4 and 5, that is a GFR, there is a creatinine more than around 3 or 4, you might add, if they're already on calcium channel blocker, ACE or ARB, and on a Lasix or something, or a Ditor, you can add a thiazide to it and they will get very well controlled. Because a lot of it is because driven by volume. So what about the role of spironolactone? So this is the Pathway 2 trial. Pathway 2 trial is one of the landmark trials where they studied the patient already were on the triple therapy and were not controlled for 3 months. And then they were rotated in 4 groups. That is, initially they gave them a placebo, then a bisoprolol, doxazocin, and a spironolactone. So they had a rotation for 12 weeks of this therapy. And if you can see here, spironolactone, this is the systolic blood pressure, this is the diastolic. The systolic blood pressure was much best controlled with spironolactone. So after 3 drug therapy, that is ACE inhibitor or ARB was calcium channel blocker and a diuretic, if the blood pressure is still not controlled, add spironolactone 25 milligram and it will work wonders for you. Especially, of course, but you need to monitor their potassium periodically. Now, why aldosterone is important? Because aldosterone is one hormone which has been studied in hypertension for the last 60 years. And it is shown that high levels of aldosterone are associated with hypertension, and more often with resistant hypertension. And many patients on ACE or ARB therapy, they have undergo aldosterone escape. So because the downstream pathway, they undergo escape, and therefore you need to have an anti-aldosterone therapy. And aldosterone beyond hypertension also has got a lot of inflammatory and has got effect upon the heart also, where it causes changes in the muscle and also in the kidney. So they can induce more fibrosis, and therefore it is important to control aldosterone. Now, as I said, the aldosterone per se by itself is not so much of a problem, but if you take an inappropriate amount of sodium, then it becomes really villainous. So in patients who are uncontrolled hypertension, salt reduction is really, really important, because if there is increased aldosterone and you're taking a lot of salt, they can really cause the harm to the blood vessels as well as to the kidneys. Now, why was this aldosterone important? So this was the Framingham study which showed that patients who were before hypertension, they were classified according to what was their basal aldosterone levels. And they found that those whose aldosterone levels were higher, they were more likely to develop hypertension, telling us that aldosterone actually is an important hormone. And if your aldosterone graded to the amount of salt intake, if you're taking low salt and your aldosterone is likely to be high, but if you're taking higher salt and still your aldosterone is high, which is supposed to go down, then you're more likely to develop hypertension. This again was shown in another study that in resistant hypertension patients, untreated or step 1 or step 2, step 3, all of them had a higher aldosterone levels, telling us that a small rise in the aldosterone, which should not be there, they are the culprit for a lot of the uncontrolled hypertension. But the problem is that we have the aldosterone antagonist, spironolactone, as I talked, is a very effective therapy, but it has its side effects also. And the two main side effects of this therapy are gynecomastia, if you use it longer, and hyperkalemia. And it also is dose dependent. So higher the dose you use, especially if you use it to a dose of 150, which you generally do not use, you get almost 50% of them likely to get gynecomastia, which is a very troublesome side effect. So what are the options available to it? So the options available is either you can reduce the aldosterone synthesis. So at the zona glomerulosa, you block the aldosterone synthesis, and therefore aldosterone is not produced. That is one strategy. Another is to use therapies which have the effect like aldosterone antagonist is spironolactone, but do not have the side effects like gynecomastia. And we shall see which are these two strategies which are currently likely to be available, and some are available also. So the first strategy was to use the CYP 11B2 blockade. Now this, when you block, this was a drug that is baxdrostat, and when you block this, you only block the aldosterone synthesis, but you leave the cortical synthesis absolutely away from it. So you only block, very selectively block this. But why it took so long? Because this was known almost 50 years ago that you could block this pathway and get away. But the problem was that aldosterone synthase, that is CYP11B2, is almost 93% homologous to 11 beta hydroxylate, that is CYP11B1. So these two have 93% homology. So whenever you try to develop an antagonist to it, it had to be specific. And it was a struggle of 50 years that now they've been able to get molecules which are very specific to block aldosterone synthase. And when you get this molecule, you find that it blocks the aldosterone synthase. So when you block the aldosterone synthase, the upstream, that is the 11-deoxycorticosterone, goes up, which is rightly going up, but the cortisol remains normal, telling us that this is very specific for aldosterone only and does not affect the cortisol. What about, this was a trial which was a phase 2 trial recently published in New England Journal of Medicine, not very recent, but some time ago. And they showed that there was a significant drop in the blood pressure, especially when you use a dose of 2 milligram of baxdrostat, there was a reduction in the blood pressure. And as expected, there was in the placebo arm also there is some reduction in the blood pressure. This is because when you're doing clinical trials, the patients are expected to take the therapy very strictly, the baseline therapy. And whenever you do that, even the placebo shows some reduction in the blood pressure because they are taking the therapy very well. But compared to that, the bardoxolone had a much greater drop. So this is the drug which you must keep a watch, is likely to come. It's in the near future. But there are some problems with it also that I just listed some of it, that there is accumulation of the deoxycorticosterone, and we do not know what it will do to other MR receptors which are beyond the, in other organs also. And unprotected cardiac mineralocorticoid receptors may remain active locally, and they might have some problems. And severe hypoaldosteronism may develop, which is a defense against some of the crises. So we need to really see whether this therapy in the clinic also does very well. So what about other non-steroidal mineralocorticoid inhibitors? So I said that one strategy is to block the synthesis of aldosterone. Another strategy is to tweak the spironolactone molecule so that it has all the good benefits of reduction of blood pressure, but does not have gynecomastia, does not have hyperkalemia. So if you see the mineralocorticoid hormone, it is actually goes into the cell, and then it acts onto the genes which it upregulates or downregulates. What spironolactone does is that it just blocks the mineralocorticoid receptor. And what the non-steroidal mineralocorticoid receptor antagonists do is that they combine with the mineralocorticoid receptor, but they tweak it such that some of the co-receptors are modified, and therefore it only activates those pathways which are important for hypertension or for fibrosis, but not so much for hyperkalemia or gynecomastia. So they are, because these are, because if you know, the steroid hormones act through activation of the genes, and they activate a large number of genes, and what these newer therapies are doing is that they activate only some small set of genes which are important for hypertension, which are important for fibrosis, but not so much for which are involved in gynecomastia and other problems. And this is how a smart pharmacology they have done to get us to there. And so if you see here, the spironolactone is the drug which is very effective for blood pressure control and organ protection. Eplerenone is similarly so. Exacerone is actually the drug which has effect on the effective on the potentially for reducing the blood pressure. Findrinone, which is currently available, Carendia, has very little antihypertensive effect. So don't use that for antihypertensive purpose, but you may use it for cardiac failure or reduction of diabetic nephropathy. Since there's a limited time, I thought you were given me 20 minutes, but it seems to have shortened it. But I'll just talk a bit about endothelin. This is the exacerone data which shows that there's a reduction in the blood pressure. I'll talk a few lines on endothelin. Endothelin is a very small peptide which causes increase in the blood pressure. And this was discovered long back, and as you all know that endothelin combines with the ETA receptors and causes vasoconstriction, and it combines the ETP which causes vasodilatation through the nitric oxide generation. And the first therapy was bosentan. Bosentan unfortunately failed because it had a lot of edema and hepatic dysfunction, but it was good in pulmonary hypertension because the dose required in pulmonary hypertension is much lower than that required in systemic hypertension. We now have a new drug which is aprocitentan, which is likely to cause a reduction in the blood pressure through the endothelin antagonist. And this is the trial which has shown that if you use this therapy, then you get a significant reduction in the blood pressure, and if you stop it, again the blood pressure starts going up, telling us that it works. But the problem with it is that it causes some degree of salt and water retention, so you get edema with endothelin antagonist. But it is very effective, and it is likely that there are about at least 10 endothelin antagonists in the pipeline in different indications, both hypertension and non-hypertensive situations. And so for the edema purposes, a lot of it people are trying to combine with SGLT2 inhibitors so that you get less edema and you may still get the beneficial effects in diabetic nephropathy and in hypertension. So because it does not induce hyperkalemia, it may be useful in situations where you can't use the aldosterone antagonist, which I discussed earlier. So in short, we have all gone through, so probably we will see more of aldosterone synthase inhibitors and non-steroidal MRA like exacerone coming in this group where they have less hyperkalemia and do the same job. And probably in situations where there is a hyperkalemia problem, we might use endothelin receptor antagonist or non-steroidal MRA like exacerone, which has less hyperkalemia. So in conclusion, aggressive management of both lifestyle and pharmacotherapy are essential to control blood pressure and reduce the rate of progression of CKD. Newer therapies like aldosterone synthase inhibitors or non-steroidal mineralocorticoid inhibitors and endothelin antagonists are likely to further provide options in the treatment of hypertension. And I think I'll end here. And of course, the most important thing is to measure the blood pressure in the most correct way. And if you don't do that, then you may not get it right. Thank you.
Thank you.